Good afternoon, and welcome to the Brain and Behavior Research Foundation's Meet the Scientist monthly webinar series. I'm Dr. Jeff Borenstein, BBRF's President and CEO. Today, Dr. Lois Choi-Kain will present online video education and assessment to empower individuals with borderline personality disorder. BBRF is the world's largest private funder of mental health research grants, supporting transformative discoveries in order to develop improved treatments, cures, and methods of prevention. The high quality of the research we fund is made possible by the BBRF Scientific Council. This group of 187 prominent mental health researchers reviews each grant application and selects the most promising ideas with the greatest potential to lead to breakthroughs. The Scientific Council guides the Foundation to fund creative and impactful basic, translational, and clinical research relevant to the whole spectrum of mental health. One reason that research funded by BBRF has had such a great impact is because we do not limit our focus to one illness or condition. Since 1987, the Foundation has awarded more than $440 million to fund more than 6,400 research grants around the world and across a broad spectrum of brain illnesses, including addiction, ADHD, anxiety, autism, bipolar disorder, borderline personality disorder, depression, eating disorders, obsessive-compulsive disorder, post-traumatic stress, schizophrenia, as well as suicide prevention. Today, I'm delighted to introduce Dr. Lois Choi-Kain. Dr. Choi-Kain is director of the Gunderson Personality Disorders Institute at McLean Hospital and assistant professor of psychiatry at Harvard Medical School. She was a 2021 Young Investigator. Our webinar will begin with Dr. Choi-Kain's presentation, which will then be followed by Q&A. To submit your questions, please use the questions tab on the control panel on your screen. Feel free to submit your questions at any time. I'll ask as many as is possible in the time allotted. And now I'm pleased to introduce Dr. Choi-Kain. Lois, the floor is yours.
Thank you, Dr. Borenstein, for that introduction, and thank you to all of you who are out there. I hope to present on our project that's aimed to increase access to care. So I thank you for your attention. Before I get started, I want to disclose my conflicts of interests, the most relevant one being that I receive royalties for the sale of books on good psychiatric management. And I also want to acknowledge and express my gratitude to all the people who make the work that we do possible at the Gunderson Personality Disorders Research and Training Institute. I have two other research partners, Brad Reish and Jenna Trainer, who have also been supported by the NARSAD Young Investigator Award, along with many other collaborators, including Rebby Ratner, who has participated in the development of our video prescriptions, as well as the guidance of our mentors, Carrie Ressler and Shelley Greenfield. And lastly, but importantly, our donors who make our work possible. So for today's agenda, I'm going to start by reviewing what the current state of knowledge about BPD and its treatments, and highlight the problems of accessing the care that has been shown to be effective for its treatment. And lastly, I'll introduce a description of our project for online psychoeducation and assessment as a means of addressing these urgent and critical gaps in care. As a starting point, we should review BPD's diagnostic criteria. One of the easiest ways to approach this is to think about BPD symptoms in terms of domains of difficulty. The first domain is the interpersonal sector of psychopathology, which includes symptoms such as frantic efforts to avoid abandonment and unstable relationships that alternate between idealized views of those relationships and devaluation. We think this is the core and discriminating feature of borderline personality disorder. But the symptoms that bring these patients to our attention in the clinical world include the self-endangering impulsive behaviors that include suicidal and self-harming tendencies. We believe that these symptoms are also driven by emotional dysregulation, which is at the basis of dialectical behavioral therapy, a major treatment that's known to work for the treatment of BPD. And lastly, there are cognitive features that include feelings of paranoia and dissociation that arise transiently under stress, as well as a distorted, unstable sense of self. One way that we can depict the relationship between these symptoms and their tendencies is to start with that interpersonal core that I mentioned. More recent scientific literature points to the fact that sensitivity to stressful events in one's interpersonal environment activates arousal, which relates to emotional dysregulation tendencies that precipitate negative and reactive mood states, especially anger. It's thought that these two core features or central nodes of borderline personality disorder then impairs cognitive control that feeds into the impulsivity that we see that is characteristic of the disorder and its self-endangering tendencies. And then that also dysregulates cognitive functions that make sense of what's happening in one's social environment and leads to these stress-related symptoms of paranoia and dissociation. All these realms of instability then undermine the process of developing a coherent and consistent identity that it functions to guide and organize a person's behaviors and make them more relatable to others. All of these domains of dysfunction are severely disabling and cause a great deal of pain to patients. We know from the epidemiologic literature that this is a common disorder that affects 1 to 3% of the general population in both adolescents and adults. And there are comparable rates among men and women in studies that assess the general population, although studies that have used clinical populations report that this is more common in women than men. The good news is that we know these patients will actively seek care. They have a high utilization of healthcare services at all levels of care, including primary care, outpatient psychiatric treatment, inpatient units, as well as in acute settings such as emergency rooms and inpatient settings with suicidal ideation. Scientific studies show that amongst those patients in psychiatric acute settings who present with suicidality, about half of them will meet criteria for BPD. We also know the rate of suicidality amongst this population is very high. A majority of patients with BPD will engage in some form of suicidal behavior. Studies estimate the average number of attempts is 3. And in the suicide research literature more generally, we know that 1 suicide is completed per 23 attempts. This tells us that there's a lot of opportunity to intervene to prevent death among suicidal patients with borderline personality disorder. But determining how we can predict those most at risk is still a work in progress. Self-injurious behavior is not often lethal, but it does contribute to increasing suicidal risk in this population between 2 and 30-fold. And this is thought to happen because it decreases barriers to harming oneself. The current estimated rate of suicide now ranges between 3 and 10% and remains 50 times greater than that seen in the general population. Assessments of BPD-related symptoms are critical because we know these symptoms of identity problems, frantic efforts to avoid abandonment, and emptiness predict suicidality. The cost to those who bear this disorder and to the communities they live in is quite high. In European studies, we know that both direct costs of treatment and indirect costs of lost productivity culminate to up to $50,000 annually. And that ranks BPD as a more costly disorder than depression and anxiety disorders in the community that this study was done in. In the US, the cost for treatment is astronomical and barely affordable for most. And we know that early BPD symptoms increases the risk of being unemployed and disabled significantly. The good news is that longitudinal studies have taught us that the prognosis can be positive. A majority of patients will achieve symptomatic remission, that is less than 5 symptoms, over 10 years' time, and will decline in their average symptom count from 6.5 symptoms at baseline to about 1 or 2 at the end of a decade's follow-up. The most common of these features tends to be anxiety and depression when alone, earning the disorder the characterization of being a disorder of intolerance of aloneness. The problem we're facing in the field is that functional changes don't keep up with the symptomatic remission. In a different study that followed outpatients in several different academic centers over decade of time, found that despite widespread symptomatic remission, functional changes were not seen over that period of time. We see here in the global assessment of functioning score that they were quite stable and lower than the levels of functioning for other patients with personality disorders or those with major depressive disorder. And the detriments of BPD have to do with its interference with developmental opportunities. BPD symptoms are known to predict academic functioning. Its features are associated with difficulties with behavioral problems in school, as well as completion of academic tasks. And we know that these patients are more likely to have difficulty completing school at different levels. The good news is those patients who can achieve remission are more likely to have good work and school performance and a sustained work and school history that paves a path to future. In particular, self-harm and impulsivity, as well as affective instability, uniquely contribute to problems of academic achievement and social adjustment. After the period that people tend to be in school, there are continuing problems of a similar sort. BPD predicts occupational difficulties and is associated with conflicts at work, dismissals, demotions, unemployment, and disability, as well as rates of unemployment. Compared to individuals with other psychiatric diagnoses, BPD patients have a lower odds of to be working 9 years after their diagnosis. And again, those who achieve remission are more likely to get back on track. However, poor occupational functioning was predominantly to blame for a failure to achieve better functioning. And the idea is that work may buffer against the worst health effects of borderline personality disorder by providing opportunities to develop capabilities, enhance self-esteem, and structure social interactions with others. Because we know BPD is also associated with limited social networks. Its features are related to increased conflict and criticism in one's social network, a decreased feeling of being supported or satisfaction with relationships within that network, an increased frequency of ruptures, and a decreased feeling of social integration. And social integration is important because it affords opportunities and social mobility. The scientific and theoretical literature proposes that social exclusion impairs self-regulation. In fact, the size of one's social network predicts the size of the social parts of the brain, the orbital prefrontal cortex. And that relationship is known to be mediated by capacities to understand oneself and others in realistic and flexible ways. Bidirectionally, self-regulation also facilitates social inclusion. So addressing these problems of functionality for those who have BPD is critical. So how do we approach treatment? The problem in terms of access to care is that the state of knowledge about psychopharmacology for BPD is pretty limited. Relative to other severe mental illnesses, few RCTs have been conducted for evaluating medications for the treatment of BPD, partially because outcomes haven't been consistent or indicated that these interventions are promising as of yet. So no medication is uniformly or dramatically helpful, and none has been licensed by the FDA. Despite the fact that most people with BPD are on medications, oftentimes for the treatment of their comorbidities, many regional and national guidelines for the treatment of BPD recommend against their use. The treatments we know work are those that are intensive, specialized, and psychotherapeutic. The most well-known of these treatments is dialectical behavioral therapy. This is a treatment that works by providing skills to support the vulnerabilities that patients with BPD have so that they can become more emotionally regulated, attentionally regulated, and effective in their behaviors and their relationships in accordance with their goals and values. This is a pretty intensive treatment that involves about 3 weeks of psychotherapy, both in individual and group formats, as well as round-the-clock paging and consultation team. There are 2 other well-known treatments that have been proven to work that work by focusing on interpersonal functioning. The first of these is mentalization-based treatment, which is also an intensive treatment involving individual and grouply meetings for the patients, as well as a supervision team for clinicians. And this treatment works by strengthening the ability to mentalize under stress that is related to insecure and disorganized attachment activation. That is the stress of what happens in close relationships. Similarly, transference-focused psychotherapy, which is a twice-weekly individual therapy, focuses again on how people think about their interactions with others. And it aims to achieve more balanced, integrated, and coherent ways of thinking about oneself and others by examining the interpersonal dynamics of the therapeutic relationship. The last of the treatments that I'll name today that have been proven to work is good or general psychiatric management that was based on APA guidelines for the treatment of BPD, as well as a textbook John Gunderson wrote called the Clinical Guide for the Treatment of BPD. This was used as a comparison treatment that was reasonably informed, structured, and employed by people interested in treating patients with this disorder, and was compared to adherent and well-run dialectical behavioral therapy in a trial that was run by Shelley McLean and her colleagues. That trial showed that there were no differences in outcomes across different domains of symptoms for patients who were enrolled in these 2 treatment arms. That really demonstrated that a more pared down generic treatment approach may achieve the results that patients and their clinicians are looking for. And GPM works by facilitating BPD's natural course of improvement and fostering corrective experiences through supporting a patient in functioning through getting a life. Now, the problem here is while there are many resources in terms of alternatives for treatments that may work for these patients, the supply is inadequate to meet public health needs. In this study that we published on the supply and demand of BPD-specific treatments, we found that no system can carry these treatments on a broader scale. Even in the most well-resourced nations, we see that there are not enough treaters available to employ these specialized treatment approaches for the patients who will seek care for their BPD. In many countries, such as Turkey and Mexico, people who see patients will have to see upwards of 70 patients per provider with BPD if every clinician in the mental health world saw these patients. But if we depend only on specialist treatments for BPD, we will see that even in the best resource nations, that each clinician will have to see over 600 patients seeking care. And in most regions, this is completely untenable. We see here that if all clinicians who served patients with psychiatric disorders saw patients with BPD, the US would be able to provide care for those who seek it. But if we rely only on specialist interventions, we will only have one clinician per 6,000 patients seeking care. That suggests that this will never be an adequate solution for meeting public health needs. But if we can make it more possible for most clinicians to provide some care for these patients, we might have more of a chance where most clinicians can provide some care for BPD using more available resources. So as I've mentioned, the limitations of these treatments include a limited supply to meet demands, also high dropout rates in randomized controlled trials of these treatments, especially in the first half, and high non-response rates that have been found across studies. From this, we conclude that one size of treatment does not fit all. And we're going to have to diversify the resources that we employ to meet the needs at different levels of care. In other words, we have to tailor the resources that we offer to meet patients where they are able to connect with psychiatric interventions. So in order to do this, we have to distill the common features across the treatments for BPD that work. And we know across the treatments that have an evidence base that there is a well-specified formulation of borderline personality disorder, structured treatment with selective focus, clear aims, and consistent procedures, as well as the activation and maintenance of a strong and durable treatment relationship that weathers the storm of its symptoms. In common factors research for psychotherapies, which proposes that shared factors contribute more to the desired outcomes than specific factors, we find that there's a certain set of ingredients that drive change for patients with many different diagnoses. This starts with a patient who comes to treatment with a maladaptive self-concept that you may be broken beyond repair or that the world will never provide solutions that meet your needs. Treatments provide a more constructive therapeutic concept that reframes experience to provide optimism and remoralization. And this provides a different set of foci that create expectations for change. They're areas that patients can concentrate on, attend to, and focus on in order to drive their lives forward. This will enable clients to independently cope with their difficulties and feel more capable of being in the world. And BPD psychotherapies have some common features to their shared formulations of how borderline personality disorder works. The first component of these formulations is that people with BPD develop the disorder because of a combination of vulnerabilities that are endowed biologically and activated in adverse environments. These factors combine to produce the BPD symptoms that we've talked about, which then go on to interrupt typical developmental processes that facilitate the development of specific emotional and social cognitive abilities that enable a patient to navigate the world effectively. This second level of difficulties then contributes to a tendency to experience oneself unpredictably and to lack a sense of consistency or confidence in one's ability to manage. This creates a sense of fragmentation in oneself and makes it more difficult for others in one's social world to relate stably and maintain relationships with people who have BPD. And these treatments employ common processes that improve self-awareness and self-concept clarity, increase top-down cognitive control, that means increase the capacity to attend to, process, and understand more realistically what goes on, so that people can organize more effective responses to their life challenges, and then experience themselves more positively in these corrective experiences that promote agency and functioning. We think the starting block of this process is providing a diagnosis, and clinicians reasonably fear that the diagnosis will be damaging to patients because this is a highly stigmatized disorder. And Time magazine in the early 2000s indicated that borderline personality disorder was among the most stigmatized disorders in the field of medicine among professionals. But studies have proven that patients with BPD who are told about their diagnosis tend to be as satisfied with the evaluation they receive as patients who have other diagnoses. And qualitative studies show that the diagnosis generally brings validation and relief, and the majority of patients report acceptance and interest in the diagnosis. The problem is that many report the gap between the age of onset of the disorder and the disclosure of the diagnosis is quite long, about 15 years. And this unfolds the derailment of development that I've presented on earlier in this talk, and provides certain added burdens and disabilities to the patient's kind of load of burden. And even when the diagnosis is disclosed to adolescents, where the diagnostic disclosure is more controversial, adolescents in general found the diagnosis accurate and did not experience it as negative. People who have lived experience of BPD have reported on the process of recovery that starts with feeling stuck in life. And they oftentimes describe that there's no clear conceptualization of what they're going through and no focus for how they can manage their problems differently. Patients have described feeling like they're floundering, getting bounced around in and out of hospitals, and having no insight into what they are doing. The process of beginning change has been reported to relate to receiving a diagnosis. And this has been called a clear turning point in developing a clear concept of experience and a pathway to understanding one's emotions. Patients report that having the diagnosis helped them to describe what was going on and helped them feel that they weren't alone, since other people had experienced these difficulties as well. They also additionally reported that not receiving any information when they're diagnosed with BPD is probably the most damaging aspect of the diagnostic disclosure. But the diagnostic disclosure tends to be the beginning of improving experience, which starts with developing a greater awareness of emotions, oneself, and one's impact on others. And this leads to a realization that their survival has made them stronger and that they do have capabilities within themselves. And with added insight, they are more cognitive of the work they need to do to recover. So just to review, diagnosis in psychoeducation plays an important role in moving patients from a point of stuckness and feeling lost to active engagement and hope that brokers investment in treatment and meaningful activities. That is the kind of soil in which patients can improve their experiences and grow a greater understanding and sense of control over their emotions, themselves, and their relationship with others. So we propose that psychoeducation is a first step of good care. We know in the treatment of other psychiatric diagnoses, including mood disorders, anxiety disorders, and other behavioral difficulties, that psychoeducation is essential. However, studies of the effectiveness of psychoeducation for BPD remain quite limited. The major studies that in the literature have been done by Mary Zannarini, and it started with a single workshop that was provided by a research assistant, educating patients about the disorder, its causes, its course, and its treatments. And they found that compared to a wait list, people who received the psychoeducational workshop experienced decreased impulsivity and unstable relationships over the following 12 weeks. This demonstrates that psychoeducation, even in a single workshop, is a useful and cost-effective form of treatment. Zannarini and colleagues extended this study by doing another randomized control trial on online psychoeducation, which involved 2 arms of treatment, including an internet-based psychoeducation module versus a control group. And they found that the psychoeducational group experienced a decrease in symptoms in all 10 outcomes over both 12 weeks time, during which patients had access to the online psychoeducation, as well as in follow-up 12 months later. This group had a larger decline in all BPD symptoms than the control group and a larger increase in psychosocial functioning overall. Lastly, our colleague Maria Rodolfi has conducted a controlled trial of 6-session GPM psychoeducation group in a community-based outpatient sample, and they found that group psychoeducation yielded greater improvements in emotional, interpersonal, and cognitive symptoms at the end of treatment compared to waitlist. And this improvement was sustained 2 months after the completion of the group, with 46% of the treatment group achieving over 50% reduction in symptoms, compared to 3% of the waitlist who achieved the same results. So this brings us to the rationale for our project on online video psychoeducation and assessment to empower individuals with borderline personality disorder. Online video prescriptions is an accessible, low-cost means of providing educational resources for patients who are newly diagnosed with borderline personality disorder in any treatment setting. Oops. We know that the intensity, duration, and training requirements of evidence-based treatments limit their scalability. And many clinical professionals without specialized training need resources to tailor care for patients with BPD as a first step of care, to bridge them from the state of stuckness to a state of engagement with change. And this would not require extensive training. Informational videos are routinely used in general healthcare and psychiatry and shown to be safe and effective. For example, they're used to orient patients to procedures such as ECT and surgical interventions. So we believe this first step of treatment can be employed in a variety of acute psychiatric settings where evidence-based treatments are not compatible, and in generalist mental health settings and primary care settings. Online psychoeducation provides a low-burden intervention that can be easily disseminated. During the quarantining period of COVID, I was impressed with the breadth and scope of information on YouTube. And this includes many psychoeducational resources out there, such as Borderliner Notes, which features experts on BPD educating the public about what they know. And what I found impressive about this channel is its high usage rate, as well as the kind of conversation and dialogue that was generated about these videos that reflected encouragement, remoralization, and benefits from viewing these videos online. We know that online videos are highly accessed by the public and professionals, and that 70% of adults in this country access the internet for health information generally. A survey by the Pew Research Center reports that 75% of decisions made by individuals using internet searches are informed by content online. But these videos vary in quality and accuracy of information. Those produced by governmental and academic institutions have the highest reliability, but need testing for effectiveness. And that's what we aim to do. In addition, we want to assess online clinical means of assessment, neuropsychological testing, and feedback, because we know that clinical trials employ these routine symptomatic measures to assess change. But in the general clinical community, less than 1/5 of clinicians utilize such standardized measurement tools in the care of patients. But they would benefit from doing so to guide their own decision-making and to justify the treatment that they're applying. So clinicians need resources to assess and measure symptoms in order to better understand patients and evaluate the interventions they're using. This can improve the problems of self-awareness when these assessments are shared with the patient. And there's preliminary evidence suggesting that receiving feedback on neuropsychological testing may be associated with improved quality of life and a sense of personal mastery. So we propose that diagnostic disclosure and psychoeducation can provide some forces that facilitate top-down regulation as a mechanism of change. And we feel that the experience of mastery and increased knowledge from the psychoeducation may improve cognitive control, thereby reducing symptoms. So the questions we want to answer in our study include the following. Is online psychoeducation and assessment feasible? Does a preliminary step of reliable psychoeducation aimed at self-clarity and engagement improve symptoms, cognitive control, and interpersonal functioning? And does the addition of online assessment with personalized feedback enhance improvements? So this is how we aim to do it. We have produced 10 6-minute prescription videos that are designed to be delivered to participants' smartphones over a course of 14 days. So there will be 10 videos released in 2 weeks, Monday through Friday, with breaks on the weekends. The topics covered in these videos include a review of BPD symptoms, a description of the model that BPD is driven by interpersonal hypersensitivity that causes the oscillations in symptoms that we see with patients who have BPD, where they may transition between states of being collaborative and connected to states of being more threatened and aggressive to states of feeling more alone, impulsive, despairing, and suicidal. This is followed by a review of basic facts on the prevalence and heritability of BPD, helping patients to understand they're not alone and that there are causes that can be understood that contribute to the risk for developing the disorder, followed by a report on the long-term course that's designed to facilitate hope that things can get better, but that patients will need to work on improving their functioning in a more concerted way. The last video in the first week reviews the pattern of comorbidity that patients with BPD will experience, that is the co-occurring disorders they'll generally have, as well as a organized approach to prioritizing the treatment of one disorder over another. In the second week, we review key principles of treatment, common factors that drive the treatments that work, the use of medications and BPD, psychotherapies that work for the disorder, namely DBT and MBT, and we end with a review of top tips for treatment. This is an example of a snippet from these videos produced by Rebbe Ratner and her production team. As we discussed, BPD is a common psychiatric disorder that many people will have in their lifetime. We also discussed how BPD is caused by a combination of biological and environmental factors. This means that you were born in a way that made you susceptible to stressful experiences. And then those stressful experiences alter your development to make it difficult for you to cope and for you to relate stably to others. And another video on interpersonal hypersensitivity. It's really to instruct you that it's important to lean into your relationships and try to work things out as you alternate from being connected to being threatened. What you're going to need to learn is how to communicate better about how you feel, what bothers you, and what you need. This will stabilize your relationships so that you don't end up in a situation where you're constantly rejected and feeling alone and desperate. So after the administration of these 10 video prescriptions, we're going to do a number of assessments. They start before the introduction of the video with a number of self-report questionnaires that assess borderline symptoms, rejection sensitivity, loneliness, levels of personality functioning, which assesses dimensional factors of personality, as well as treatment history. They're combined with some neuropsychological online tests that are housed on Laura Germain's platform, Test My Brain, which I'll show you in a moment. This is combined with daily EMA, that is ecological momentary assessment of various facets of functioning and interpersonal interactions, along with cognitive control. And throughout the assessments, we continuously look at BPD symptoms, the acquired knowledge from the videos, as well as different levels of rejection sensitivity, whether that changes over time, as well as loneliness. Lastly, we monitor what treatments patients or participants receive during the course of the study. The neuropsychological testing is done by this platform called Test My Brain, which is an initiative that provides testing online with personalized feedback to help participants learn about how their own mind works. And this contributes to a number of research studies. I mentioned these daily assessments that occur for a period of 30 days, and they involve questions about the general functioning the participant has, their social functioning, their reports of their interpersonal experiences, as well as their performance on this gradual onset continuous performance test of attentional regulation. For half the participants who watched the BPD videos, we're going to actually provide feedback that's descriptive of their reports and performance on these assessments so that they get some sort of information about how they're doing, what changes for them and what doesn't change for them, and how they're performing compared to norms. And this will give them a pattern of how their cognitive control functions over the period of the study. So as a summary, we're trying to improve patients' knowledge about their disorder to organize an understanding of themselves and their problems objectively and constructively. This involves providing online psychoeducation about BPD, multimodal periodic online assessments, feedback that's coherent and relatable regarding symptoms and cognitive changes, to foster growth via increased understanding of one's disorder and the patterns that impact their life. We hope this empowers people to have a framework for thinking about themselves and others more constructively and provide hope of change. So in conclusion, I want to just review the fact that BPD is a prevalent, disabling, and potentially fatal illness that can be treated and improves over time. Interventions designed to be adapted to and feasible for healthcare professionals to employ without extensive training are needed to increase the scalability of basic healthcare for BPD. We feel that these psychoeducational videos, which we have the opportunity to assess through the support of BBRF, are broadly accessible resources that can improve mental health literacy for individuals living with this disorder, and that the addition of online assessment will provide efficient and accessible evaluation of outcomes and may be an intervention in and of itself. Thank you for your attention, and I'll take questions.
Lois, I want to thank you for really an outstanding presentation. You provided a lot of information in a very user-friendly way, so thank you for that. Has this approach been tested? Are you already doing this with people? What's the status of the process right now?
We're about to launch the study in January, actually. So the videos have been developed and edited. We've created a platform online to administer the assessments, and the IRB has passed and the clinical trial has been registered. So we're ready to go.
Excellent, excellent. And how can people become a part of this once it starts?
We'll be recruiting subjects in Massachusetts, recruited from different hospital settings that have had a recent diagnosis of BPD to participate in our trial. So if you're in Massachusetts and have a recent diagnosis, you can look for information about our trial online.
Excellent. And obviously, once this is, if and when, proven to be effective, then it can be more broadly available to people.
Absolutely. And our hope is that if generalist clinicians, both in mental health and in primary care, have more accessible and easily implemented tools to begin care with patients, they may have a very different experience of working with these consumers and feel themselves remoralized and reduce their stigma towards the disorder. So we're hoping that these videos, if they become available as a clinical resource, will not only help patients, but will destigmatize the disorder for a broad range of professionals.
I think that's a very important point, that the stigma and prejudice that exists both in the public and among professionals is a tremendous obstacle. I want to ask you about the families, the loved ones of people who have borderline personality disorder. What types of interventions could be helpful to them in terms of working with their loved ones?
I'm glad you asked that question, because family or social network support for individuals who have BPD is incredibly essential. People with BPD cannot kind of survive on treatment alone. They will need support in their kind of general social world to sustain them. And that support will be stabilized if family and friends know more about the illness. That is, that they too need psychoeducation. And there are many organizations that provide both education and support for family members. NEA BPD is one of them, as well as TARA for BPD, and many other organizations provide such support, and they organize groups where family members can meet other family members who have similar struggles, and they too can know that they're not alone. These organizations provide families with practical tools to manage stressful situations and respond in a way that's helpful. In addition, there are other support groups for patients, including Emotions Matter, and many international organizations that provide resources to support people with BPD in the community.
Good, excellent, thank you, thank you. In your presentation, you spoke about comorbidity, and I'd like you to speak a little bit more about what are some of those co-occurring conditions that happen in the context of BPD?
Well, the most common co-occurring conditions are mood and anxiety disorders, as well as post-traumatic stress disorder and alcohol use disorder. And the general principles for managing those comorbidities is to think about what the priorities in intervention may be. Because we know the treatments for borderline personality disorder require active learning, we would recommend that clinicians and patients work on stabilizing disorders that interfere with cognition first. These disorders include mania with bipolar illness, attention deficit hyperactivity disorder, which can be treated with medications, as well as eating disorders, which have to be treated with more multimodal, psychosocial, and medical interventions. But most disorders, such as mood and anxiety disorders, can be, the treatments for those disorders can be enhanced by prioritizing the treatment of BPD. We know from longitudinal research studies that the presence of BPD diminishes responsiveness of patients to treatments that generally work for the co-occurring disorders, and will decrease the likelihood of remission or increase the likelihood of relapse. So by targeting BPD in addition to mood and anxiety disorders, you can improve outcomes on both fronts. And lastly, for disorders that have indicated exposure therapies such as PTSD, OCD, and panic disorders, addressing the problems of BPD first can enable patients to feel more prepared to manage their activated vulnerabilities in the treatments that are indicated for these other disorders. Recently, there has been more work on combining treatments to target common comorbidities that interact to complicate care. And those two major sets of comorbidities have to do with PTSD and substance use disorder. There's been some progress in the development and testing of treatments that address both BPD and complex PTSD, or BPD and PTSD, and those are generally based in dialectical behavioral therapy. And while these are comprehensive and effective treatments, they're not as widely available as would be needed. So more work has to do with disseminating those treatments and finding more accessible treatments that can be implemented in addition. One area that needs a lot more work is treatment development for the co-occurrence of borderline personality disorder and substance use disorder. And our group is working on developing good psychiatric management for BPD and alcohol use disorder, which is quite common and unmanageable in many BPD-focused treatments and substance use disorder treatments. So we feel that combining treatments that work and can be more generally implemented is needed in that set of co-occurring disorders. So we're working with experts across both domains to develop a generalist approach that incorporates the standards of care for both treatments, as well as some fundamental ideas from dynamic deconstructive psychotherapy that was developed by Robert Gregory, which has some good evidence of efficacy.
Thank you. A lot of information in there, all very useful. You spoke about suicide risk, and I'd like you to speak a little bit about suicide prevention, which is such an important issue for all people, and in particular for people with BPD.
This is an area where we have to do a lot more work to understand the differentiation of suicidal thinking and suicidal action across different diagnoses, but especially with BPD. Because the majority of patients with BPD will experience some level of suicidality under stress, understanding who's more at risk and who needs higher levels of care is really important. What we would suggest is that people use the general principles they know for the good care of patients more generally when they're working with patients with BPD, and understand the universal risk factors, that is, past attempts, family history, co-occurring substance use, the presence of depression, recent discharge, and assess other factors like access to means. Along with this, you can understand the vacillations of symptoms within BPD to understand when someone's feeling more threatened and they have impulses to be aggressive towards oneself and others, versus when people are more seriously hopeless and despairingly suicidal. We feel that people are more at risk in these more hopeless states than in the kind of aggressive activated states, where they're still trying to make efforts to engage, communicate, and address the problems they're facing. They just do so in a way that's difficult for others to understand and collaborate with.
The very important information. One final question. Often people with BPD may be resistant to treatment. What do you say to somebody listening right now who has a loved one with BPD, but is having difficulty getting them to accept treatment, to accept care? What do you say to somebody in that situation?
Well, that situation is incredibly painful because loved ones really want to see the suffering and the instability of their relative reduced, and that comes from a good place. But at the end of the day, patients will need to be empowered and encouraged to take control of their own problems through having access to information that's optimistic, constructive, non-judgmental, and useful. And that's why we think psychoeducation can help, because if it's online, the patient can, the person with BPD can access it on their own terms and think about it at their own pace. So all that clinical professionals and loved ones can do is offer this information to provide a turning point that it can be for some patients, and wait for that time. In the meantime, they can do well by offering consistency, support, and transparency in their communications about how their loved one is causing them concern and how much they want them to get better.
Lois, I want to thank you for the work you've done, the work that you're going to do. Thank you for joining us today with this outstanding presentation. So thank you so very, very much.
Thank you for having me, and thank you to all of you for listening.
I also want to thank everybody who joined us today and ask you to please consider making a donation to BBRF. 100% of every dollar donated for research is invested in our research grants. We can do this because our operating expenses are covered by separate foundation grants. This means that when you donate $1 for research, that dollar goes to the scientists. To make a gift, please visit bbrfoundation.org or call us at 1-800-829-8289. This webinar has been recorded. If you've missed any portion of the presentation or would like to share it with family, friends, please visit the events and webinar page on our website. I'd like to invite you to join us again on January 10th at 2 p.m. Eastern Time, when Dr. Erin Kalapari, Assistant Professor of Pharmacology and of Molecular Physiology and Biophysics at Vanderbilt University School of Medicine, will present Sex Differences in Mental Health Disorders. Thank you, and remember, together we can dramatically improve the lives of those living with mental illness and enable more people to live full, happy, and productive lives. I want to wish everybody a happy holiday season and a happy and a healthy new year. Take care.